Hello, and welcome back to the VJ Hem-Onc podcast. In today's episode, you'll hear some recent interviews with experts in the field of sickle cell disease, which will focus on several crucial aspects in the management of this blood disorder. Topics covered include transitioning from pediatric to adult care, managing vaso-occlusive crises, and whether routine brain MRI assessment should be performed in patients. This podcast is part of the non-malignant channel on VJ Hem-Onc, which is supported by Agios. This supporter has no influence over the production of the content. This podcast is intended for healthcare professionals only. To begin, you will hear from Samah Babiker and Payal Desai, who outline the challenges patients with sickle cell disease face as they transition from pediatric to adult care services, and discuss how clinicians should approach this transition.
So the transition of sickle cell disease patients from pediatric center services to adult services can be quite a challenging period. It is a critical period for those young adults. They often find that there can be certain fears or anxieties around the time of transitioning from children hospitals to adult hospitals, mainly because of fear of losing that long-term relationship with the pediatric providers, of having that fear of losing the trust that they have developed throughout the years. Some of them also find that they are suddenly faced with a lot of challenges of that age anyway. So it's quite difficult being a teenager generally, let alone having to navigate a complex healthcare condition such as sickle cell disease. Now we know because of the advances, or historical advances in children's care, sickle cell disease is no longer a life-threatening childhood disease. Instead, it is now a chronic life condition with life-threatening complications. Advances such as penicillin prophylaxis, vaccinations, and stroke prevention mean that 95% of children with sickle cell disease live and survive well into their adulthood. So then they tend to develop accumulated comorbidities throughout these years as they grow into adulthood, but also they can accumulate some psychological challenges and some maybe socioeconomic challenges as well, and including some other academic changes and physical changes. So it's safe to say that the transition period through adolescence is a very delicate and difficult time for most people with chronic health conditions, including sickle cell disease. So as clinicians, I think our main goal is to ensure that we, first of all, start preparing these young adults very early on. So in our center, we start at the age of 12 years, just to talk about transition and to explain to them what we expect to achieve in the next few years until they are ready enough to go into adult services. So one of the things we always talk about is increasing self-advocacy, increasing confidence, and those things come along with good knowledge about sickle cell disease. So in the preparation period, as clinicians, we need to ensure that we identify any gaps in their knowledge, rectify those gaps straight away, immediately, and also see if there are any other concerns in that young adult, because not one size fits all in transition. Some young adults are very concerned about their physical appearances, their societal relationships, while others are more concerned about their mental health and their academic progress, etc. So having a process that identifies these concerns and their gaps quite early allows us to, if you want, tailor a transition program that is individualized for that person, and that patient with sickle cell disease needs to be at the heart of this. So it has to be patient-centered, and it has to be as tailored as possible to these young individuals so that they can grow into more independent, more self-confident young adults that are hopefully going to be well integrated into adult services. So our goal is to have a young adult who understands their condition, quite knowledgeable, who understands self-advocacy and confidence and independence, who is seamlessly integrated into an adult service without gaps in their attendance, without gaps in their medication adherence, and also somebody who wants to lead a good, fulfilling life with sickle cell disease and not in spite of sickle cell disease. So that would be our goal, and that's, in my view, how we say that we have had a successful transition for a young adult. And the way we achieve it is variable, but we, for example, have a transition tool that we use to assess these young adults and then create a tailored program around them, and then, have a multidisciplinary team around the young adult to allow them to progress seamlessly. And that consists of pediatric providers, adult providers, nurses, psychologists, etc. But I think you can still achieve successful transition even if you don't have that setting, as long as you have a good intention to start early and build slowly to make sure that young adults develop the skills necessary to help them lead a good adult life that is completely well integrated and as safe as possible for them?
So I think one of the interesting things, and this came up again at the ASCAP meeting, was some of those transition barriers occur a little earlier than we think. So we think about transition at like 18, 20, 21 into an adult program. But some of those patients are lost a little earlier. So even starting by age 14, where they're not necessarily coming to visits in the pediatric side. And then when they get to that transition age, they're already lost and don't show back up until they're like 21, 22, 25, where they start having major complications. So I think one of those challenges is really identifying those high-risk patients early. The other barriers are, I think, if you've had the same team taking care of you since you were, that you can remember your entire life, building those relationships, developing trust, and meeting those teams early on, I think is really important too, so that you can feel like you can have that smooth, comfortable transition and develop those same types of relationships with the adult world. But they take time. And especially if you've seen the same group for as long as you can remember, that's a challenge, having to develop those new connections and relationships. There is a new publication that came out of the National Alliance of Sickle Cell Centers that looks, I think one of the things is we all talk about transition as kind of this entity, but we haven't even had standard definitions of how we look at transition. What is transfer of care? What is true transition? And how do you define transfer versus transition? So transfer is you get to that first or second appointment. Transition is that on the adult side, you truly identify a medical home, that you know that there's a group that's there to take care of you. You can identify who you see for your sickle management, who you see for your kidney management, who you see for whatever other complications you might have, and feeling like they're your medical home, feeling like there's a group that can take care of you, and really you can reach out to them as your place to really get those connections. So I think I would highlight that recent publication from the National Alliance that actually finally defines those things for us so that we can start looking at it structurally in the same way. So we can start having the same definitions and say, okay, here's the barrier to transfer. Here's the barrier to transition. How often are people really attending all those follow-up appointments? And is it the first appointment that's a problem? Or is it in year 2 or 3 where you become maybe less engaged? And what are the things that people are seeing around that time? I think the other part is sometimes you don't have anybody to transition to. So we're starting to build more and more community, but having adult providers that are well-versed in sickle cell disease and have a true comprehensive center, not just a clinic, is very difficult. And there are not enough of those places. So I think that's one of those other big challenges during that period. And the adult hospitals definitely feel different. The feel is different. The approach is different. The people are different. And the priority sometimes in really busy spaces on the adult world can feel very overwhelming and challenging to try to get care for chronic illness, for all chronic illness.
Next, Enrico Novelli will share insight into the management of vaso-occlusive crises, highlighting the importance of developing individualized care plans for patients and considering non-pharmacological approaches.
So for vaso-occlusive crisis, the mantra is that we must believe the patient's report of pain because we don't have quantifiable objective biomarkers of painful crisis. So sometimes some patients do. If you follow the labs, you may find that some patients do have worse hemolysis when they are in crisis, lower hemoglobin, but these are not universally detectable changes in the common laboratory measures we have at our disposal. So it's important to believe the patient. It's important to treat the pain quickly. All guidelines recommend that the first dose of pain relief should be given within 30 minutes, and then the patient, the analgesia should be reassessed at frequent intervals with frequent redosing of opioids opioids are still the mainstay of treatment for acute pain, it's also important to use a patient-controlled analgesia wherever possible for pain. And we know that this is a safer and more effective way to control pain. And ideally, patient-controlled analgesia should be available in the emergency department for those patients who are going to be hospitalized once the bolus, the boluses have been completed. Patients should be immediately transitioned to patient-controlled analgesia, with which they can go to their respective floors. Unfortunately, that's not always available, and sometimes between the emergency department and the hospitalization, the admission to the floor, there is a gap in analgesia that is very problematic. It's also well known that if you do have an infusion center or a day hospital, patients should ideally be treated in these types of settings rather than the emergency department, because in the infusion center and the day hospital, there is a staff that is familiar with the patients and can provide the best care, the most empathic and holistic care. We know it's also very important for each patient to have individualized care plans that have been developed specifically for them. So these are bespoke plans for each individual patient that take into account their tolerance to pain medications. They incorporate what has worked before, and they should provide multiple instructions to the providers on not just opioids, but other supportive care and other medications to deal with the side effects of opiates. And they may also have specific information for each patient about allergies that might be important to their care. So this is very important. And so opioids are critical. In some patients, acetaminophen and non-steroidal anti-inflammatory drugs may also be helpful. We know that for some types of pain, non-steroidal anti-inflammatory drugs are beneficial, but it's important to be mindful that kidney function tends to deteriorate as patients age, and so a lot of NSAIDs can contribute to deterioration of kidney function. Other pharmacological assets are medicines that target neuropathic pain, such as gabapentin, pregabalin, duloxetine, and others. These are beneficial for patients who have developed neuropathic pain. And then for non-pharmacological approaches, unfortunately, are not as developed as they should be. But a lot of patients will tell you that applying warm compresses to areas of pain is beneficial. Rest and relaxation are also important. Rest and relaxation. Some patients do report that complementary medicine approaches with acupuncture or massage are also beneficial. But unfortunately, these approaches are not always available. They tend not to be covered by insurance, and so so they're rarely available to patients who need it. But I've even heard that Reiki is beneficial in some cases for patients with sickle cell disease. So these are all strategies that should be investigated in the future, and actually should be investigated now, to be honest.
Finally, Subarna Chakravorty will comment on whether MRI brain assessment should be routinely performed in all patients with sickle cell disease.
So this was an interesting session. We had a discussion. It was more like a conversation rather than a debate that we had in the ASCAT conference this year. And personally, I think we might need to differentiate between MRI scans in children with sickle cell anemia, in this case, so SS and S beta 0 thalassemia, rather than any other type of sickle cell disease. And in my mind, and based on what is clinical practice and evidence, I think it's definitely helpful, and it should really be done in all children with sickle cell. In an asymptomatic child with sickle cell anemia who has regular transcranial Doppler monitoring, I think there should at least be one MRI scan done at a time when they are able to stay still and not need a GA or a general anesthetic for an MRI scan. And I think there can be a lot done based on what you glean from that information. And to me, the purpose of screening anybody for any condition is really predicated on the fact that you can do something about it. So there's not much point in screening for something that you can't do anything about. So, for example, if you had a child who comes up with significant, let's say, silent cerebral infarctions, then there are, you can be more careful about what kind of interventions you offer for that particular child. I would, in my own mind, feel that maybe doing one MRI scan in sort of late primary school age and then doing another MRI scan at kind of late secondary school age before they transition to adults is probably the best way of doing it. So the problems that you see in the late primary school age might be quite different from the problems intracerebrally that you see in the late secondary school age, where we are particularly interested in seeing if there are any aneurysms or if there is any ongoing problems with cerebral vasculopathy, particularly at a time when you've stopped screening for transcranial Doppler because they've gone past 16. So in children, I think it's a lot more straightforward. It's a lot more cut and dried. You can investigate them and then initiate some kind of treatment, which could even include discussions about stem cell therapies if you find all of a sudden that there is significant vasculopathy, which you haven't been able to pick up on a TCD scan. With adults, it's a little bit different, in my view. I think in principle, one might feel that, every adult should have an MRI scan at some stage of their lives, particularly, I guess, in the younger age when there is ongoing risk of intracranial hemorrhage due to aneurysmal disease, for example. But I think it's difficult to have an open-ended plan of screening, say, annual MRI scan or a 5-yearly MRI scan, because partly you're kind of likely to become stuck as to what you do once you find what you find, because what we know about children and the risk of strokes and any kind of cerebral vasculopathy is very different from what you see in adults, and particularly when the older the adult becomes, the more there is cardioembolic strokes, etc., etc. So they're kind of a slightly different way of approaching. So I know that there was a discussion about sort of, functional MRIs, to look at cognition, etc. And again, it's great that these things are available and people are having the funding to use it, to access it. But actually, it will be quite a lot of input and potential area of parental and patient worry, particularly patient worry when they're adults. And I'm not entirely bought up with the idea that this should be universally to everybody. But in theory, yes, for a young adult, just getting into the adult care, it's good to have a baseline to know what your patient has already had in terms of cerebrovascular disease, particularly if they've not had anything in their early childhood. And finally, just before I stop, now curative options are offered to many, many adults, and having that baseline is also very helpful, because then you know that if they've got an undiscovered stroke, let's say, in the past, it's helpful to delineate that in case, as you what you do with the patient in terms of referring them onto gene therapy or bone marrow transplant. I think it will have a great bearing on which pathway the patient might take.
That's all the insights we have for you today. Thank you for tuning into this episode. To explore more updates in sickle cell disease, make sure to visit the non-malignant channel on vjhemonc.com. Don't forget to follow us on X at VJHemonc to stay in the loop, and subscribe to our podcast on Spotify, Apple or Podbean so you never miss a new episode. Until next time.